All right, so we are now recording and we're going to cover the content both from your study guide as well as what you can expect to see on your exam. Now again, obviously, I'm not going to go over the exact exam questions because to be quite honest with you, I'm not finished building it yet. So, everything on this exam will be based on one of those objectives in that study guide. So if you're very well versed with that, you should do perfectly fine. So one of the things I want us to be able to do is to trace a drop of blood through the heart. Now, let's think about this for a second. We're going to start with the superior and the inferior vena cava. What do they do?
Bring blood to the heart.
From
The rest of the body.
All right, specifically, where does the superior vena cava bring the blood from? Okay, yeah, very good. So it's from the top of the head down to the heart itself, and therefore the inferior vena cava would bring the rest of the body from the heart down to the soles of the feet. It goes into the right atria. Remember, the right atria is very, very small, about the size of half of the distance between your thumb joint and the tip of your thumb. But now remember, the atria can expand out, so that's why it's able to take in a considerable amount of blood. Once it leaves the right atria, it goes through the what? The tricuspid valve down into what? Right ventricle. The other thing I want you to remember about the circulation of blood through the heart. Now, again, particularly when we get into advanced cardiology, we'll talk about circulation of blood in the heart. And that's entirely different than going through the heart. In the heart, we're talking about the heart tissue itself being perfused. But for right now, we're just talking about passing through. The right side of the heart is considered what? High pressure or low pressure?
Low pressure.
It is low pressure because it doesn't have to send it very far. Okay, it doesn't have to send it very far. Once it leaves the right ventricle, it goes to the lungs by way of what? Pulmonary valve that goes into the pulmonary artery. Now remember, arteries carry blood away from the heart. Veins bring blood back to the heart. Very, very good. Once it gets into the lungs, it goes in and around the alveoli. Now, I want you to, again, dig deep into this whole understanding of the diffusion process that takes place within the lungs around the alveoli, okay? So again, remember the alveoli are grape-like clusters, and we got tons and tons and tons of capillaries that go around them, and the red blood cells now come into lining up single file to go in through there. When the red blood cells have left the right ventricle and they're going to the alveoli, they are high in what gas? Say it again. CO2. Good, Tacey. Excellent. Very, very good. So they're really high in CO2 and they're very low in oxygen. When it gets to the alveoli are low in CO2 and high in oxygen. And remember, the whole process of diffusion means that a gas will diffuse from an area of higher concentration to one of lower concentration until the pressures are equal. And that's how we get rid of CO2 out of the body. It diffuses out of the red blood cell. Some of it's dissolved in the plasma. Don't worry about that for right now. And it diffuses over into the alveoli. Well, the alveoli is high in oxygen. The exact same thing happens, except in reverse. And now it comes back into the red blood cell. Leaves the red blood cell, and it comes back to the heart by way of pulmonary vein. Pulmonary vein, which dumps into the left atrium, and it goes through the bicuspid, okay? Remember my stupid little memory aid. You want to try before you buy. And then it comes down into the left ventricle. Now, what is really important to remember about the size of the left ventricle.
It's the largest one because it does the pump the most to get over the aorta.
Very good. Right. How much of the heart does the left ventricle make up? Braden. 75%. Excellent, sir. Very, very good. Okay. And it is that large because of exactly what Skylar just said. It's got to pump the blood out through the body. Okay. Now, when it leaves the left ventricle, it goes to where? The aorta. Very good. Remember that. Remember that. Now, the other thing you want you to remember as far as the circulatory process, and it's outside, is that now when that oxygenated blood gets to its target cell, the exact same thing of the diffusionary process that happened around the alveoli happens with the cell. Because remember, the red blood cell is now coming around, going down to your big toe. Your big toe needs some oxygen. Red blood cell high in oxygen, low in CO2. Because of metabolism, the cells in your big toe now are high in CO2, low in oxygen. The exact same thing happens. The capillaries go around the cells. They go in single file. High oxygen red blood cell diffuses oxygen into the cell. High CO2 in the cell diffuses back over to the red blood cell, all to begin repeated again. Okay? Questions about that? Now is the time to ask your questions if you don't understand about anything that we're going to cover today. Everybody feel okay with that? Next slide, you guys are actually pretty good at this one. I don't know why my remote is not wanting to work. Here we go. Okay, because you guys were joking with each other, I think, on Monday about, okay, where's the base and where's the apex of the heart? All right, so where is the base and the apex of the heart? Yeah, Tasty, very good. The base of the heart is the very top, and the apex is down at the very bottom. All right, so let's get a few more people involved in here. Okay, it'll help me again to remember your names that I have not learned yet, but I promise you that I will. Gabrielle, in what direction do the atria and the ventricles contract, and why? Yep, I ask you first. So let's take the atria. Do the atria contract from superior to inferior or from inferior to superior? Somebody help her out.
Superior.
And then what do the ventricles do? Yeah, so the atria are on the top, so they go from the top down. The ventricles are on the bottom, so they go. Okay, now don't mess with me there, okay? Anatomically speaking, work with me here, okay? And the ventricles are anatomically on the bottom part of the heart, so they go from the bottom up. Now, why is that important?
Because otherwise, it's a pump. So
Uh-huh.
you have to fill up the starting part of the pump, low pressure, high pressure side of the pump, in order for that to push it to the rest of the body.
Okay, so you're about 85% of the way there. But now remember, we have two atria and two ventricles. Only one of the atria is low pressure, and the other atria is high pressure. Same way down for the ventricles. Again, this is why I have this question here. It goes directly back to the question about tracing the drop of the blood through the heart. Gabrielle, I think you were going to say something a minute ago, and I cut you off. Perfect. Because remember now, as we go here, let me get my laser pointer so both of you can see. Here is our atria. Here are our ventricles. Remember, the atria is sending blood this direction. The ventricles are sending blood this direction. This is sending blood out into the lungs. And when it leaves the right ventricle, it goes superior to go to the lungs. When it leaves the right atria, it goes inferior to go into the right ventricle. If it did any other way, there will be no cardiac output. Okay. So again, atria contracts because all of their blood is coming this way. And then the ventricles contract because all of their blood is going that way. Questions? Yes. I will use the word superior and inferior. Let's talk about that for just a little bit, okay? A little medical terminology. When we're talking about superior, we're not talking about being over somebody, but what we're talking about is a point on the body. So superior means the highest point in reference. So when we're talking about the heart, we're superior part of the heart. We're talking about the base of the heart. And then when we're talking about inferior, we're talking about the apex of the heart. So again, the blood flows from superior to inferior from the atria and from inferior to superior in the ventricles. That's a very good question. Thank you. Anybody else? I love questions. You don't need any help getting in trouble. All right, let's move on. Okay. Now, remember, we talked about the vagus nerve. What does the vagus nerve do, and how can we manipulate it to control or to slow the heart rate? Absolutely, it does. It definitely has something to do with the sympathetic and the parasympathetic. Kyle. All right, very good. So now let me ask you a question here. When we take that deep breath, the body recognizes something, Abe, and it secretes a specialized neurotransmitter. What were you going to ask or say? Yeah. Yeah, anything that's going to increase the pressure, a deep breath. Coughing isn't as effective because we have just a short time in there of where the pressure is going to be. And it may take anywhere from 10 to 30 seconds for the pressure to be enough that now begins to have an impact on the vagus nerve. But bearing down with patients that have a really fast heart rate, and again, we'll talk about these when we're talking more about atrial rhythms. So putting pressure on the vagus nerve will slow the heart rate down. It does this by secreting a specific neurotransmitter. Now, what is a neurotransmitter? That's the first part. It is a chemical that does what? How's it do it? Not Braden, not quite. Hold on just a second. Braden. Well, it has to do with electric. Well, oh, no.
They're different shapes that have connector things.
Yeah, okay. So think of locking keys. Okay. I have a bunch of keys here for this building. Some of them I have no idea what they fit, but I'm afraid to throw them away. I do know that this key right here will open my office. Okay. This is an example of a neurotransmitter. It goes into the key and it unlocks my office. A neurotransmitter fits into a receptor site on a cell and it causes something to happen. Okay. It causes something to happen. All right. And all neurotransmitters and all receptor sites all have different responsibilities, just like I have different types of keys. So the neurotransmitter that is secreted when we put pressure on the vagus nerve, acetylcholine. And so what happens is when we put pressure on that, it actually blocks that and it slows the heart rate down. But the big thing I want you to remember for right now is putting pressure on the vagus nerve slows the heart rate down. Everybody good?
Where is that?
Starts right here in the base of the brain, comes all the way down, goes through the esophagus down into the heart, and then it winds up down here in the gut. Okay. The vagus nerve helps to give us part of our intuition. One of these days, I'll share with you how that actually works. Many times emergency responders will look at a patient, and the patient will be fine, and they'll say, "Well, my gut says there's something wrong with this patient." Listen to your gut. It won't always be right, but the more experience you get, the more accurate that your gut actually becomes, and this has been proven scientifically. We'll talk more about that in another session. Excitability, conductivity, automaticity, and contractility. What is excitability? Kyle. You're close, but not quite there.
Flight responses?
Not quite.
The ability to react to an electrical impulse?
Yeah. So basically, think of dominoes. We have, we've seen some really quite awesome looking domino setups that do some pretty cool things. Nothing happens until a domino gets tipped over. Ideally, it's the first domino. The energy from that domino is passed on to the second one, and it does the exact same thing until the whole gamut has been run. The same thing happens in the heart. When the SA node fires, it shares that electrical impulse with the cells that are around it. They share with the cells that are around it. So the ability for a cell to accept and to pass on that impulse is called excitability. Conductivity, what is that? That is the ability to carry electricity. Not all cells can, okay? Your bones, they're not conductive, okay? Your muscles are, all right? And so that's that ability to carry the electricity. Now, Kyle, tell me what automaticity is. Which other organ in the body has the same ability? Nope. Remember, the brain uses electricity, but what the brain does is it reacts to signals. No other organ in the body has the ability to generate its own impulse. And remember, again, especially as we're moving out of sinus rhythms into other types of rhythms, every cell in the heart can do this. That's why this automaticity property can be an awesome thing for survival, or it can be what will kill us. Okay? And so you got to remember that. Contractility is just simply the ability of the heart to stretch and to snap back. Okay? Stretch and snap back. Questions on those four words? Stroke volume. Okay? Stroke volume is the amount of blood that is ejected out of the left ventricle with every contraction. Okay? With every contraction. Stroke volume depends upon preload and afterload. So let's talk about those for just a minute. Somebody give me the definition of preload. I'll take that, yeah. So atrial volume would be another way to define preload. Okay, so when there's more blood that's going into the atria, the volume is greater. Therefore, your preload is also greater. Now, this is a key thing to remember. If we want to increase cardiac output, we want to get more out, we increase preload. Okay? Unlike the United States government, any party, I don't care, pick either one of them you want, the body can't spend money that it doesn't have. Yeah, sorry. So the bottom line here is that if we want to increase increase cardiac output, one of the ways that we do that is by increasing preload. Remember, preload and cardiac output go in the same direction. If we drop down preload, give me an example of how you would reduce or how preload would be reduced in the body. Say it again.
Resting.
Mm-mm. That wouldn't reduce preload. That would definitely reduce like heart rate, and that does have a role to play in there. But remember, we're talking volume. What would be something that could happen that would reduce the volume of blood? Okay, I'll take that. Yeah, congested arteries. So if the arteries are not functioning correctly, we could have a problem that's coming through. The one I'm thinking about is, Friday night gun and knife club. Okay, somebody gets shot in the abdomen. They're either bleeding internally or they're bleeding out onto the ground. They're losing that blood. And that, say it again. Vasodilators will actually have an impact on afterload. So I love being around smart people. You're one step ahead of me, but we're coming there. So hold on to that. So remember, volume is what preload is. What's afterload?
It's how much is left over after the contraction. It's the actual output. Pressure.
Say it again. I couldn't have said it better myself. So remember, okay, if we have, I don't see any markers. Okay, I'm not going to use it. If we have an artery that is like this, and the heart is pumping out through this artery, okay, there's a certain amount of pressure that the left ventricle has to overcome in order to fill up that artery. What's going to happen to that pressure if everything remains the same and now that artery is that size? The pressure is going to go up. Afterload is going to go up. Think of afterload as being almost identical to blood pressure. Now, everything being equal, are you going to pump out more blood with the artery this size? Or we're going to do the optometrist thing again. Does it look better this way or this way? Which one would have more blood? The larger one. The larger one, okay? So now, this is another important thing to remember. Preload, afterload go in the same direction. We change preload and cardiac output go in the same direction. We change preload, cardiac output goes in the same direction. Not so with afterload. We increase afterload, cardiac output does this. One of the ways that we can fix and help our cardiac output is to change our afterload. This is what we were talking about as far as vasodilation just a second ago when you brought it up. We can dilate that artery a little bit more, kind of going along with the line of what you said about arterial congestion, to get more blood to go through in there. All right, let me stop just a minute because I got to tell you, preload, afterload, cardiac output are critically important understanding to the success of your career in EMS. Questions?
This entire time I'm thinking about the type of ball used to prime like a boat.
Mm-hmm.
And so preload being how much fuel you're actually getting in when you release the ball.
Yep.
If you don't have an adequate amount, so you need to suck a little bit of air.
Okay. Yep.
So that's squeeze.
Less is going out.
Output 2 is really small. It's going to be really hard to squeeze. And the pressure is going to be a lot higher at the other end too.
Bingo. That's a great example. So you kind of think about it that way. That's excellent. You had your hand up.
Just said preload is the atrial volume.
Yeah, it's the volume of blood that is delivered back to the heart. Now, obviously, when the blood comes back to the heart, the first place it goes is into the right atrium. That's why when he said atrial volume, I said, okay, I can go with that because that's where it starts.
What was your definition?
I just simply said the volume of blood that's delivered back to the heart in general. You were a little more specific, and I was okay with that. Now, does that help you? Are you okay with that? Kyle? Oh, yeah. Yeah. So the thing to remember is, again, when let's talk about preload. You get shot. Poof. Okay. Now, preload drops because we're losing volume. Okay. Here's the other thing that happens, though, is that the body, in response to that drop, will do its best, and you'll learn more about this when we talk about shock, to take the vessels from this size to this size. Because not only does the body need volume, the pressure has to be high enough to circulate that all of that blood through the organ and out of it. So preload and afterload have a huge impact on cardiac output. Anybody else? Yes.
Just to clarify, so afterload would be the amount of force or the amount of volume it takes for the left ventricle to push through?
Is pressure, the amount of force. Okay. Say it again.
What unit of measurement?
Millimeters of mercury. That's what your blood pressure is. This is why high blood pressure is such a killer in the heart. If the patient's blood pressure is up and the vessels are constricted for years and years and years, guess what happens is that the heart, especially the left ventricle, is increasing that pressure. Now, let's think about this for a second. If you lift weights, why do you lift weights? What's the purpose?
To increase, well, it depends, honestly.
It's hypertrophy, isn't it?
Okay, you're close. You're trying to increase your muscle size, in essence, to increase your strength. However, one of the things you got to remember is that if you lifted weights and you lifted weights and you lifted weights and you lifted weights and you never had a period of rest, eventually, okay, Bill having a stroke, take 2. Eventually, your arms and your legs would get big muscles, but they would be flabby, kind of like me, flabby. The heart does the exact same thing. Always under pressure, the heart, it starts out, oh, this is good. I'm getting stronger. Then eventually, if that hypertension is not dealt with, the heart begins to develop hypertrophy. Okay? The medical term for that is actually called cardiomegaly. Don't worry about that. We'll talk about that in advanced cardiology. But the heart gets large and floppy, and it no longer functions, especially the left ventricle, as an efficient pump. We okay on preload, afterload, stroke volume, and cardiac output. Awesome. What's Starling's law? Rubber band principle. Faith, tell me more.
It's basically like the more it stretches, the more pressure is.
As I said, the more the harder the contraction.
Yes.
He was zipping her back up. Yeah, you're exactly right. Very good. Now, remember, there's a limit to this. It's like everything. Kind of like ice cream. Ice cream is good, but there's a limit to how much you should eat. If your heart is stretched all the time, now we wind up with cardiomegaly, an enlarged heart. Okay? And now the heart becomes flabby, floppy, and does not work as an efficient pump. There are ways, especially when you get into the sequence in the fall and you come into my trauma class, we're going to talk about how you as a paramedic can actually use Starling's law to help increase your cardiac output. We're going to save that for another day. Yes? Starling's law is the greater the stretch of the heart to a point, the greater the contractile force. Now let's think about this for a minute. If we increase the contractile force of the heart, what do we do to the cardiac output? We increase cardiac output. Yeah, very good. But now if that heart is always under pressure and we've increased it and we've increased it and we've increased it, eventually it becomes floppy. And what happens to the rubber band if you keep that rubber band stretched? Let's say this rubber band's only about that length at rest, but we keep it stretched out here. What happens to the rubber band? It's never going to go back, and it's liable to break. It is now weakened. That's why stretch the rubber band, you use it, and then you take it off. Are we good on that? All right. Intrinsic pacemaker of the heart is what? And its intrinsic pacing rate is what? 60 to 100. In order for it to be a bradycardia, what does the rate have to be? Below 60. Same way with tachycardia. Above 100. So 60 to 100 inclusive of 60 and 100 is a normal heart rate. What does the word chronotropy mean? Say it again. In regards to the heart, what do you think that would refer to? The rate. The rate. Okay. So if we want to, let's say we give a positive chronotropic drug, what do we expect the heart to do? The heart rate will go up. Again, Faith, coming back, I think, over to your question earlier, one of the ways that we can manipulate cardiac output is we can increase the patient's heart rate to a point. Like everything, it has its limits, because when we get, especially when we talk about tachycardias that are coming from the atria, you can have tachycardias that are like 180, 190, 200. Trust me, that is not compatible with life. Okay? So you have a kind of a law of diminishing returns. Cardiac output will begin to go down somewhat. Inotropy refers to what? Say it again, Abe. Contractile force. If we give a positive inotropic agent or a positive inotropic drug, what we've done is we've increased the contractile force. We can manipulate this again with medications, with fluids. Dromotropy. Tell me more. What about the electrical activity?
Would it increase the excitability or the?
You're getting closer. You're getting warmer. Braden? You're getting much warmer. Dromotropy refers to how fast the electrical impulse goes through the heart. Now, a couple things that you can keep in mind. Sometimes the heart has an electrolyte imbalance, which slows the dromotropy down. If we have a bunch of dead tissue, because remember, dead tissue does not contract and it doesn't conduct electricity. So the heart, as it's in here, if this is a bunch of dead tissue, the electrical impulse goes, oh, wait a minute, road's closed, now we got to go around this way, and it slows down the dromotropic effect. Okay, so chronotropy refers to heart rate. Inotropy, again, goofy way that I help to remember is inotropy, in, out, in, out. And dromotropy is the speed of the electrical conduction. What are the three most important electrolytes that I need you to know about, and why are they important to the heart?
Sodium, potassium, and calcium.
Okay. Of those three, which one or ones deal specifically with mechanical action of the heart?
Calcium.
Why? Okay. So calcium is extremely important for muscle function. So if the heart is going to function, contract, we got to have enough calcium. Same way for the rest of our muscles, okay? The bones get all, and our teeth get all of the publicity. The muscles just need a better PR agent, because if we have low calcium, the muscles are not going to work. Remember, with sodium and potassium, that whole concept of the sodium-potassium pump. Potassium's inside the cell, As long as it stays in the cell, life is good. Sodium's on the outside of the cell, okay? But now, okay, wait a minute, Bill, you just said as long as sodium stays in the cell, but I'm getting ready to tell you that sodium goes out of the cell, and potassium goes out of the cell, sodium goes into the cell, and when they do that, we get that spark, that electrical energy. Well, the reason that I can say that it's safe for that potassium to be outside the cell is because it doesn't last long. Fraction of a second. Fraction of a second. We'll talk more about and exactly what you were saying a while ago about to kill a person, either like for capital punishment, or some places have used this as a type of assassination of giving a massive dose of potassium. It literally unplugs the heart.
Calcium?
Potassium. Did I say calcium? I meant potassium if I did. Potassium. So remember, sodium, potassium deal with the electrical aspect of the heart. Calcium deals with the mechanical action. Kyle. Oh, okay. No problem. We've already talked about the vagus nerve, so we're in good shape with that one. Sympathetic nervous system does what in the body? Yeah, think of the sympathetic nervous system as kicking everything into overdrive. Okay, so sympathetic nervous system gets us ready to do really cool things or to defend ourselves or to take one of Bill's exams. Parasympathetic nervous system calms everything down, slows everything down. Alpha and beta receptors. Alpha receptors, we have multiple alpha receptors, but for cardiology, where are the alpha receptors? Not in the heart. Nope. Blood vessels. When we activate the alpha receptors, the blood vessels do this. They constrict. Now we got a bunch more alpha, and alpha 1 is the ones for the blood vessels. Okay. The beta receptors we find, again, multiple different places, but we find certain beta receptors in the heart and other beta receptors in the lungs. We have the beta 1 in our one heart, and we have the beta 2 in our 2 lungs. When we activate the beta receptors, what does it do to the heart? 2 things. That's one thing. What else does it do? Well, it could, yeah. So increase. The ultimate is to increase preload. So if we're increasing the heart rate, remember what else is most likely going to happen as well. A blood pressure, but we're talking about specifically on the heart. That's the end result, but contractile force. Yeah. So we increase chronotropy and inotropy. Okay. This is why, again, you might want to do a little bit of research, not for the exam, just for your own knowledge, because you'll definitely need it if you come into, if you haven't taken pharmacology yet, or if you haven't taken, well, nobody has, advanced cardiology. One of the most common drugs that your patients will be on are beta blockers. Guess what? Beta blockers slow the heart rate down and they reduce the contractile force for good reasons. Okay. What do beta 2 receptors do when they are activated in the lungs? Bronchodilation. You will have medicines that you will give that will activate the beta 2 receptors. That's a very, very good thing. What's the primary neurotransmitter for the parasympathetic nervous system? Acetylcholine. You listen, very good. Intercalated disc. What are intercalated discs? Kyle. Yeah, very good. So if you work in public safety, I may have shared this with you before, again, you're probably familiar with the repeater system. Places like Willie County has got to have them because there's no line of sight because of the mountains. And basically what happens is you have a repeater up here, you have a small wattage radio down here. It hits the repeater, and the repeater increases the amplitude of the signal to send it on to the base station. Intercalated discs do something that's really similar, except instead of increasing the energy, they increase the speed. So that's why when the SA node fires, it's almost, not quite, but it's almost instantaneous of that impulse going from the SA node over to the both atrias and down to the ventricles to cause depolarization, which hopefully results in contraction of the heart. All right. Anybody questions about the intercalated disc?
What properties about the section between the SA and the AV node physically slows down the electricity?
The cells themselves. Yep, the cells themselves. No, it's just when you share electricity, the longer your line runs out, and you see this quite often with like when you're doing audio visuals for a concert or a church or something, the longer the line is between the microphone and the person that's controlling it, the more resistance that they're going to have. So there's ways that you can adjust and account for that. I don't understand them. But the intercalated disc will do the exact same thing. It will speed that impulse up because, again, as you're moving through cells, it's just naturally going to slow that impulse down if there were no intercalated disc. All right. Important things to know. Know the conduction system of the heart, please. Okay. Know that this is our what? SA node, and it comes over to the left atrium by way of Bachman's bundle, and these are known as what? Internodal pathways, coming down to number 2, which is, say it again, AV node. Okay, good. And 2A is bundle of His. Okay, then it gets separated out into the left and right bundle branches, comes all the way down, and eventually ends in the Purkinje fibers. Remember, the impulse from the atria go inferior to superior because that's the way we want the heart to contract. The impulse from the ventricles come all the way down here, and then it gets sent back up through the tissue of the heart from inferior to superior. Okay. Why do we have valves in the heart? Yeah, what's the medical term for that backflow? Regurgitation. Okay. Why would regurgitation be a bad thing from a cardiovascular perspective?
Well, just overall reduces the efficiency of the pump.
So it reduces the efficiency of the pump. So if we have regurgitation, what happens to our cardiac output?
Decrease.
It goes down. What else happens if we have regurgitation?
Increased chance for clotting.
Okay, I'll take that. You're exactly right. Blood that sits still, even though it's moving back and forth in the atria to the ventricle, does increase to clot. What else? If we have regurgitation, let's go back right here. So if we have regurgitation where we have blood that is coming from down in here, and then it comes down in here, and then instead of going out through the pulmonary artery, it gets squirted, technical medical term, squirted back up into the right atria. What's not going to happen? Say it again. Yes, you're right. So that blood, instead of going out to the lungs for the diffusionary process to take place, it goes back up into here. So we reduce cardiac output, we increase the chance of clots, and wait, there's more. We increase the possibility of hypoxia for our patients. What are the two arteries that come off of the base of the atria that feed the heart? Now, the coronary arteries is the whole thing, but there are the left and the right coronary arteries. Say it again.
went over this.
Yeah.
It's crap.
Coronary means crown.
Coronary means crown.
Which you'd think would be up here, but I guess not.
It's around.
Don't try to figure. It's at the base of the heart, okay? So, when do the right and the left coronary arteries fill with blood?
When it pushes from the ventricle to the aorta. So it goes through the aorta and from there.
You're close. During which phase of contraction? Active or resting? Resting. Okay. The diastolic phase. That's when the left and the right coronary arteries now begin to perfuse. All right. Somebody tell me what that rhythm is. Pay attention to the hash marks. Say it again. It's regular. What's the rate on that? It is 80. Look at the hash marks. That's why I said pay attention to the hash marks. So if there are hash marks, you gotta, and I do this on purpose. I want you to pay attention. So remember, we don't count this one because this one is outside of that hash mark. So the rate is 80. So yeah, you're exactly right. So this one is indeed going to be normal sinus rhythm. Okay. What is that?
Sinus tach.
Why is it sinus tach? No, sinus tach's not too fast. It's above 100, and what else? Say it again. It's less than 140, so it's not going to be one of the other rhythms. Very good. Why else is it sinus tach? Everything's normal. We got a P wave. It's upright. All the P waves look the same. Got a P wave for every QRS. Got a QRS for a P wave. PR interval, Tacey, looks normal. QRS looks normal. What's that rhythm? Sinus bradycardia. Okay. Sinus bradycardia. Uh-oh. What's that rhythm?
Sinus block.
No. What is it? You can't just tell me arrhythmia. Sinus arrhythmia. Okay, there you go. Because you can see in here that we got this spread, and then it picks back up, and then it starts spreading back out. So that's sinus arrhythmia. All right. Sinus arrhythmia is primarily caused by breathing. It's what we're all doing in here right now. Breathing. Okay. Remember, it's the breathing. When we take a breath in, we increase the pressure on the vagus nerve, and the heart rate goes down. When we exhale, we reduce the pressure on the vagus nerve, and heart rate goes up. What's that rhythm?
That would be sinus.
What's the difference between sinus arrest and sinus block? Tell me more. How much shorter?
Bajumble.
One what? One bajumble? One QRS complex. So the distance for sinus block is you would take this distance right here and measure it, and the space that you've got in here would be twice this distance.
On that last rhythm, where it opened up, like, would there not be enough room for one?
There could be, but remember, you got to look at everything on your 6-second strip. The variation between these R to R's is what gives you the clue that this is going to be sinus arrhythmia and not a sinus block. Yeah, good. Say it again. Depends on how fast you're breathing. Yep. All right, so that is sinus arrest. Okay. What is the big concern? Bless you. What's the big concern that you have with a patient who is suffering from sinus arrest?
Yeah.
We're all going to die. That's my happy thought for the day. Now, yeah, what is the impact on cardiac output of sinus arrest, or what's the potential impact
Decrease in cardiac output.
as a result of? Close, Ian. Not necessarily, because you could have this, but basically because the heart rate drops. Okay, the heart rate drops. Okay, what's that? Nope. Remember your options. Not a sinus rhythm. Okay, you will learn what this one is, and I will tell you this is a life-threatening rhythm, but that will be in a future lecture. What's that rhythm? That's normal sinus. Normal sinus. Everything, excuse me, everything is normal about it. How about that one? Nope. Say it again. Not a sinus rhythm. Now you'll learn what this is, but for right now in your exam, all you need to do is look at that and go, that's not a sinus rhythm, Bill. That's all you need to know.
Is that P wave inverted, or is that part of the QRS?
Nope, that's inverted P waves. Every one of those P waves are inverted. Okay. What's that rhythm?
Sinus tachycardia.
What's the rate?
Oh, well, that's not the sign.
Wait a minute now. I'm not telling you you're wrong. I'm challenging you. What's the rate? Say it again. What does sinus tachycardia go up to? So what is that rhythm? That's a sinus tachycardia. Okay. Not a lot of your numbers are set in stone when we're doing assessments on our patients. It's kind of like, but these are set in stone. So anything that's up to 140 would still be considered a sinus tachycardia. If it were faster than 140, it will be something else. What's that rhythm? So I got another sinus rhythm. Anybody got anything different? Say it again. Those are not actually P waves. We'll learn what they are, again, as part of atrial rhythms, but this you would simply identify as Skylar said, not a sinus rhythm. Everybody understand why this is not a sinus rhythm? Okay? It doesn't fit into the criteria for a sinus rhythm. What's that rhythm? This one? What are these? Well, that's for a coming attraction. But I mean, do you see those in any of the sinus rhythms that we've talked about? Okay, then therefore it is not a sinus rhythm. Right. What's that? Oh, controversy. I hear sinus what? I hear sinus arrest. How many pay? Everybody's got to vote. Okay. Sinus block. Raise your hand. You bunch of chickens. All right, so I see 3 brave people. Sinus arrest. This is sinus arrest. Okay, now remember, we got to look at this and we would measure from here to here. If it were sinus block, we would have one dropped area. So imagine measuring from this one to this one and then comparing it to this space in here. This is larger than this space to this space. Okay. Questions on that?
What if they're close. What's the big difference in terms
I will not give you anything that is really close. Not at this
in terms
point.
of real world application, if you don't.
2 small boxes or less.
That made me think of the one where the arrhythmia, where you said it could have been a block in the middle. Is it possible where the answer could be sinus block and sinus arrhythmia?
No, it would be one or the other. And the reason that this is not sinus arrhythmia is if you'll look at the R to R's, they're consistent.
Well, I mean, it was like a few back where they weren't consistent, and then there was probably enough room for.
But again, what you're looking at there is that you're seeing the progression of your R to R. So as we take a breath in, the R to R's will get longer. When you have a longer R to R, that means your heart rate's going down. Okay. And then when you breathe out, those R to R's come back to being closer.
Is that because of pressure on the vagus nerve?
Yes, because of pressure on the vagus nerve. What's that rhythm? Not sinus rhythm. Is this rhythm regular? No. Let's look at it. What do you notice about that rhythm?
The R keeps elongating. It keeps getting longer.
The R to R keeps elongating and getting longer and longer and longer. Now, you can make an argument that this could be one of two things, and I could support pretty much either one of them. You could say this is not a sinus rhythm, or you could potentially make an argument that this may be, you'd have to be really good at it though, Tacey, that this may be sinus arrhythmia. Why did I say that? There's no absolute. Say it again. Yeah. So there may be a regularity to what we're seeing here. And so if I had a longer strip, we could tell. So again, if I gave you this strip right here, trust me, I won't. But if you told me, hey, Bill, I'm going to make an argument that's sinus arrhythmia, I'd listen to your argument. Okay. And if you could tell me there is a pattern to where, if we were looking at this part right here, is this inspiration or expiration? Why? It's slowing down. Both of you are correct. Very, very good. Therefore, this part would be during expiration because it's speeding up. Ladies and gentlemen, I've gone over your entire exam. What questions do you have for me that are related to the exam? You will have the entire class period to do the exam, so there is no need to rush. I think the questions that I normally have it set at is about 50 or 60 questions, but I'll let you know before. Oh, yeah. So what's the outside layer of the heart called? The very outside layer of the heart. Pericardium. Then we have the epicardium. Then we have the myocardium. What's the inside layer called? The endocardium. Remember that death in an MI typically takes place in the myocardium. What's the purpose of the pericardium?
Protective sac.
Protective sac. It protects the heart. It's a protective coat.
Is that the hard thing that the?
It's not hard, but it's kind of like leather.
Okay, so it has a trouble expanding.
Yeah, it will not expand. The heart expands inside it. Absolutely. There's a condition known as pericardial tamponade that will lead into that.